A common misconception is that neonates in intensive care units don't feel or won't remember feeling pain. In fact, neonates are fully capable of sensing pain, and repeated painful stimuli can have permanent effects on developing neonatal somatosensory systems. Increased nociceptive input, such as heel pricking, and innocuous input, such as diaper changing, can disrupt the fine-tuning of the neonate's somatosensory system and cause altered pain responses. In some cases, repeated innocuous handling can induce neonates to display reactions to pain, such as face expression, including a bulging brow, eyes squeezed tightly together, nasolabial furrow, and mouth stretched both horizontally and vertically with a taut tongue. Noxious stimuli such as heel pricking can cause gross arm and leg clicking or flailing in addition to pain expressions in the face. There are also physiological indicators such as increased heart rate. Upon receiving a painful stimulus, the spinal cord sends a poorly fine-tuned motor reflex signal to the periphery, causing both legs to be lifted in response. This is an example of exaggerated nonspecific leg response in part due to large nociceptor receptive fields. Receptive fields refer to an area on the skin that depolarizes a single dorsal horn neuron, resulting in a signal being sent to the brain via corresponding projection neurons in the spinal cord and tertiary neurons in the thalamus. A large receptive field increases the chance of the individual dorsal horn neuron being activated by stimulus to the body surface. As well, large receptive fields increases the extent of receptive field overlap, increasing the chances of a localized stimulus lying in the receptive fields of multiple dorsal horn neurons. Having large nociceptor receptive fields causes more neurons to be activated by noxious stimuli, resulting in more signals being sent to the brain. The injury site sends action potentials to the brain where it is interpreted as pain. However, instead of the signal being sent to the brain unaltered, the signal undergoes complicated modulation in the dorsal horn before it reaches the contralateral side of the brain. Part of this signal modulation consists of descending signals from the brain. The response to a nociceptive input changes as a neonate matures. The following will explore the physiological mechanisms underlying the behavioral responses and pain sensitivity of neonates. Low threshold A-beta fibers and high threshold C fibers fire action potentials upon noxious input. In addition to being activated by noxious stimuli, factors released by the injured tissue and damaged blood vessels also encourage the depolarization of nerve fibers. Action potentials of C and A-beta fibers are delivered to the dorsal horn of the spinal cord, where they are modulated before they are sent to the contralateral side of the brain via projection neurons in lamina 1 and 5. C fibers terminate in lamina 2, and A-beta fibers terminate throughout the dorsal horn. The abundance of A-beta fibers in lamina 2 is a phenomenon only occurring in the immature somatosensory system before 35 weeks gestational age. Both C and A-beta fibers depolarize the local excitatory interneuron, which activates a pain pathway by delivering excitatory signals to the lamina 1 projection neuron. Because an abundance of low-threshold A-beta fibers are present in lamina 2 in the immature somatosensory system, lamina 2 excitatory interneurons are activated more frequently, thereby sending more signals to the lamina 1 projection neurons. At times, innocuous input, such as handling, are interpreted as nociceptive input. Inhibitory signals are sent to projection neurons to dampen excitatory signals. Local spinal inhibitory circuitry is fully functional in preterm neonates, with some C fibers synapsing onto local inhibitory interneurons to provide weak inhibitory signals to lamina 1 projection neurons. Descending inhibitory circuitry that carries signals from the brain is present, but is not functional in preterm neonates. The increased excitatory input due to A beta fibers in lamina 2 in combination with a deficiency of inhibitory signals render neonates more sensitive to nociceptive input. The increased excitability of local excitatory interneurons due to excessive A beta fibers in lamina 2 is the reason for large receptive fields for pain sensory in the periphery. As the neonate develops, key changes occur in the maturing dorsal horn that alters signal modulation, which in turn affects the ascending signals going to the brain. A beta fibers lose their synapses with local excitatory interneurons and retract from lamina 2. As a result, firing of A beta fibers from an innocuous input no longer activates the pain pathway. Inhibitory descending pathways mature and begin to effectively send inhibitory signals to the projection neuron. After the somatosensory system undergoes these key changes, the peripheral pain receptive fields of the neonates decrease to the adult size. The change in the peripheral pain receptive fields is due to the increase in inhibitory signals from the now functional descending inhibitory pathways and the decrease in excitatory signals due to the withdrawal of A beta fibers from lamina 2. The result of these changes in the dorsal horn is a more fine-tuned pain sensory pathway, and innocuous stimulation is no longer interpreted as pain. The fine-tuning of the neonate somatosensory system can be observed in a less exaggerated response when the neonate receives a nauseous stimulus. Proper input is required for normal maturation of the somatosensory system. Neonates in NICU receive repetitive nauseous stimuli at an important developmental age. Increased nociceptive input can disrupt fine-tuning of the somatosensory system, thereby predisposing neonates to enhanced sensitivity to painful events. More research, as well as enhanced understanding and communication, is needed in neonatal pain management, not only to reduce the amount of neonatal pain experiences, but also to ensure healthy development of neonatal patients.